So earlier, I mentioned trying to make people whole. Cancer and any illness has a way of taking things away from us. And in our younger patients, cancer and cancer treatments can take fertility away. And this is a very precious thing that we don't want our patients to lose. Dr. Jay Huber is a reproductive endocrinologist and infertility specialist in the New Orleans area. He's the medical director of the Fertility Institute of New Orleans. He's also an assistant clinical professor in the Department of Obstetrics and Gynecology at LSU Medical School. Dr. Huber graduated from LSU School of Medicine in New Orleans. He completed his residency in OBGYN and a fellowship in reproductive endocrinology at the Warren Albert Medical School of Brown University. And he is at a national level. Dr. Hubert's on the developmental committee of the American Society of Reproductive Medicine and is a member of the research board for the Society of Reproductive Endocrinology and Infertility. Dr. Hubert.
All right, good morning. Can everyone hear me? Good? All right, so I really appreciate the opportunity to come speak to the CAGLA conference today. I'm always moved by joining other groups, meetings. You always learn a few things. The first thing I learned this morning was how versatile the word vomit is. In the world of gynecological surgery, that's victim of modern imaging technology, meaning that they found something that we weren't looking for to begin with, right? So thanks a bunch. Dr. Ellis, thank you. Thank you to CAGLA. As an OBGYN and a fertility specialist, I consider myself what I call a roundtable doc. Not only do I see individuals, couples, families around a round table, I don't like to talk directly at patients, I like to speak with them. But also in terms of relationships in fertility preservation, it's important that I have a seat and all of our colleagues and many of you in this room, we sit around that round table to make sure that our patients afflicted with any type of gonadotoxic diseases can have the full breadth of a care team that can make our care not only expedient but effective. Going forward here. I do have a couple disclosures, none of which impact the validity of this talk. I get great pleasure from serving on some of our industry leaders and trying to further and advance some of the technologies that we do. I have a relationship with LabCorp, Hologic, and Ferring Pharmaceutical. So the goal of today is really to, number one, impart knowledge. And that knowledge really wants you guys to understand fertility preservation options for both biologically male as well as biologically female, their success rates, timing requirements, and then current guideline recommendations. We'll talk a little bit about clinical skills, some of the fertility discussions, the interventions, assessing patient goals. We want to match the appropriate preservation techniques with the various clinical scenarios, as well as coordinating care between the oncology team and the reproductive medicine team. So lastly, we'll talk about how to apply these skills, and we want to establish effective referral networks and document discussions appropriately, not only from the oncology but also from the fertility medicine piece, and provide patient-centered counseling throughout the Cancer Care Consortium. Now, why do we feel it important as a field of reproductive medicine to catch up with our oncology hem-onc colleagues? It's because you guys have gotten so good at your job that we needed to get better in our job. So over the last decade to maybe 15 years, there's been a tremendous amount of research, tremendous amount of resources that have been provided into our field in getting better in serving patients to allow them in their realm of survivorship to continue to build their family. As you know, cancer survival rates now exceed 80 to 85% in children, adolescents, and young adults. Fertility is definitely a top concern in these reproductive age patients. I will do a phone call, Zoom, FaceTime, in person, however we can get a patient seen, reproductive age patient, we welcome the opportunity. One example, I did a phone call with a 15-year-old patient at Children's Hospital, a pretty sick kiddo, and she wanted to talk with a doctor about how to have babies in the future. And we went through about a 30-minute phone call, went through the whole process of, well, we would involve injectable medications. We want to try and get as many eggs as we can now. That way, in your survivorship, we have the opportunity to build your family. And then I always tell patients, but look, if this is too much, if it's not something you're interested in doing, there are alternative strategies, such as things like donor egg, whether it's a known donor or what we call a directed donor, or a non-directed or an anonymous donor. And a 15-year-old, she says, oh, that's cool. I'll just do that. I said, great. Sounds like, look, if things change, let me know. So the fact that we were able to educate and then empower this young lady to be able to make her own decisions, just a mere phone call, 30-minute phone call, I think it's going to change her reproductive goals for the rest of her life. And that goes to say that the earlier discussions, they definitely reduce distress and improve quality of life. In reproductive medicine literature in the realm of fertility preservation, that we quote about an 80% reduction in risk of regret later in life, regardless of whether we intervene with a fertility preservation technique or not. So a mere conversation, very important. So who are the candidates for these discussions? Obviously, prior to cancer therapy, chemotherapy, radiation to the pelvis, surgical interventions for cancer treatments such as oophorectomy, hysterectomy, or orchiectomy. We also see patients who are undergoing gonadotoxic treatments for other conditions, things like autoimmune diseases, myeloproliferative disorders. We also like to see patients, and unfortunately this is fairly rare because by the time these diagnoses are made, such as Turner syndrome or a Fragile X premutation carrier, Fragile X premutation carriers are at risk for a condition that we call premature ovarian insufficiency. We'll see in just a few slides, young women are born with all of their eggs, and so it's a finite pool for which we have to work with. And then lastly, transgender patients prior to gender-affirming treatment. So as far as timing and communication, really want to start these discussions at the time and the risk at the time of diagnosis before treatment initiation. Want to have the appropriate network in place to refer interested patients and even those that are uncertain. Those that say, there's a lot going on, not sure exactly what this involves. We welcome the opportunity for a 10-minute discussion, a brief overview of what the world of fertility preservation can provide. Want to document discussions in the medical record. The nature of medicine, we all are aware. I have sat on Louisiana state medical review boards for failure to have conversations about fertility preservation later after cancer treatment. And then, as mentioned earlier, these patients are lifelong patients. We want to revisit annually during survivorship or even when treatment plans change. And I can't harp on it enough. Time is of the essence. We want to ideally complete any of these entities prior to chemotherapy or radiation. So this is just a summary of some of the more common offending agents, certainly not a complete list. But many of these chemotherapies you talk about on a daily basis. The one that gets me the fastest is cyclophosphamide. Anytime now mind you, I'm an OBGYN, I focus on the biologically female aspect of fertility preservation, and I do have colleagues that do more of the male piece. But cyclophosphamide is certainly one that we would label as high risk, as you see in that right side, in that right column. And then as we go down the list, there are some more medium risk and low risk. My opinion, any risk is too high. Now, this is not a complete list. With the advent of more advanced agents such as biologics, and in the breast cancer world with ER/PR positive cancers and utilizing hormonal treatment, the good news there is that the early evidence that we have is that those are even lower risk than the chemotherapeutic agents that you see here. ASCO did a really nice job in collaboration with the American Society of Reproductive Medicine, the American College of OBGYN, with coming up with some really nice guidelines in terms of, we all like guidelines in one place. Where can we find them? Where can we review them? and are they evidence-based, right? So ASCO did a nice job publishing these guidelines and updated guidelines in 2025. So in all patients impacted by cancer, we want to discuss infertility risk as early as possible. We want to refer interested patients over to reproductive specialists, and then documentation is key. In biologically male, we want to make sure that we offer sperm banking, which is a well-established technique, as well as in the event sperm banking is not feasible, we want to discuss offering a TESE or testicular extraction of sperm if unable to produce the specimen. Very well-established technique. Hormonal suppression with medications such as GnRH analogs to stop the hypothalamic anterior pituitary testicular axis do not show as much benefit in the biologically male population. In female, offer embryo or oocyte cryopreservation, very well established. Offer ovarian tissue cryopreservation, very newly established, right? And not only is it very newly established, it is a far more advanced technique that the access to those types of treatments are limited at current state. So we may offer GnRH agonists, so a medication like Lupron as an adjunct, specifically in the breast cancer population, but my opinion is in every patient undergoing gonadotoxic therapy, try and shut down the HPO, ovarian axis, so that the eggs kind of go into a sleep mode. And then consider ovarian transposition for pelvic radiation. So moving into more specific male preservation techniques, first line is going to be sperm cryopreservation, or known as sperm banking, right? First line for pubertal or post-pubertal males can be done very quickly, collection every 24 to 48 hours prior to starting chemotherapy. We make vials of sperm, can be utilized for either intrauterine insemination later in life if the quantity is high enough, or utilized in the in vitro fertilization technique. Even limited samples are very successful. The limited samples, we are able to fertilize eggs with a technique called ICSI, or intracytoplasmic sperm injection, where under a microscope we can direct a single sperm into the egg to help with fertilization. So when asked how many sperm do I need, I say in certain scenarios, as many as we can get. Just get me something, right? From testicular tissue, from ejaculate, whatever it is, just get us some sperm. And this should be done before treatment initiation. If unable to sperm bank via masturbation or collection techniques, then testicular sperm extraction is a very viable method. This is something where a reproductive urologist would go in surgically and take sperm either from the epididymis or directly from the seminiferous tubules in the testicle. And as well, this should be offered before cancer treatment. Just to reiterate, the shutdown of the HPT, or the testicular axis, is not as effective with GnRH analogs. Prepubertal males, testicular tissue cryopreservation definitely remains investigational. Should be done under an IRB or in a clinical investigation or a trial. Some of the post-treatment considerations after chemotherapy, there is higher risk of genetic damage in sperm collected after treatment, so our goal is to utilize sperm that is collected prior. And then sperm quality may be compromised even before treatment. So we know that, like much in healthcare, that chronic diseases can impact other biological systems such as sperm. Now, post chemotherapy, we typically recommend that if we're going to use an ejaculated specimen instead, and if we don't have any sperm that was cryopreserved, we typically give 1 year, right? A minimum of 1 year to utilize that sperm for reproductive means. The nadir, or the decline in sperm after chemotherapy, ranges from about 2 to 6 years, but many times reproductive age men do regain sperm in the ejaculate, but would not recommend utilizing that sperm for a minimum of 1 year after the last dose of chemotherapy. All right. Show of hands, anybody been in the Superdome before? Terrific. It's a local conference, so I would hope so. I use the Superdome as an analogy. I like analogies, especially when you talk about complex issues like oocyte cryopreservation, how the ovaries work, how the menstrual cycle works. So think about the ovaries like the Superdome. When young women are born, there's about 1 million eggs in the dome. By the time they go through puberty, half of those eggs go home. But what the other 500,000 do is they start to go to their seats. You've got some sitting up in the terrace in the sections, you've got some sitting in the club, and then you've got some in the plaza. And every menstrual cycle, what's happening is we have a conductor, she's out in Champion Square, she walks into the Superdome and she takes out one section of eggs. So for instance, in one menstrual cycle, she goes in and she says, okay, section 343, get up. Just the eggs in section 343, that's where my wife's tickets are. They're my wife's, they're not mine. It's 343, get up. Just the eggs in 343, get up, and they roll outside to the ramp. Now, depending on age and ovarian reserve, there may be 5, 10, 15, 30 eggs from section 343 that make it outside to the ramp. And in a normal menstrual cycle, that conductor then starts a competition out on the ramp, takes about 14 days for one of those eggs to win the competition. That's the egg that gets to ovulate. The rest of the eggs from 343 go home. They don't get to go back to their seats, right? So every menstrual cycle is just a different section of eggs coming out from the dome to the ramp. Competition starts, one ovulates, the rest go home. So in the world of fertility medicine, and certainly in fertility preservation, the way I describe it to patients is every treatment cycle that we do, we're not messing with what's going on in the dome. We're only manipulating the eggs that are out on the ramp. So with pills, we just rig that competition a little bit. 1 to 2, sometimes 3 or 4, ovulate, and that's where we get more eggs to meet up with sperm. In something like an IVF cycle, same principle. We're not messing with what's going on in the dome. So what we're doing is we're using 10 to 12 days worth of injectable medications, gonadotropins, to rig the hell out of that competition. If there's 5, 10, 20, 30 out on the ramp, we want them all to win, right? So we want every single egg out on that ramp to win so that when we go to egg retrieval, we go in with a needle, ultrasound-guided needle, and we pick up every egg off of the ramp, right? So then once we go through that process, we talk about, well, what's going to happen to the eggs in the Superdome when I undergo my treatment? That's the part where, yeah, the eggs in the dome may take a little bit of a hit based on the dosing or the type of medication or type of chemo, the type of the dosing, how long the dosing's happening, plus or minus radiation, et cetera. So that's a really nice analogy that I like to use for patients. And then I'd say, look, if we're going to use a GnRH agonist, something like Lupron, what that's going to do is we're going to try and put all the eggs in the dome to sleep. That way, when you're done with your chemo, there's a chance that some of those eggs in the sections, hopefully up at the top, in the middle, they wake up a little bit and our ovarian function is started to happen again. So going into some of the treatments that we do, oocyte cryopreservation, certainly over the last decade, has taken the forefront of fertility preservation in terms of being able to go quickly and protecting reproductive autonomy of young women after chemotherapy. It's an established method, no partner required, no sperm, nothing needed. It's very well suited for individuals with religious or ethical objections to embryo freezing. Live birth rate, pretty reputable, 32% in one study. And then ultimately the cumulative live birth rate, about 35 to 37% per patient. Second option would be embryo cryopreservation. So very established, highly effective method. Over a decade ago, when we were talking about fertility preservation, embryo cryopreservation was the one to do. Reason being is you can freeze, you can cryopreserve anything, right? It's the ability of that entity to survive the thaw. So oocytes previously were not very stable, and embryos were far more stable in the ability to survive the thaw when we went to utilize that tissue. Nowadays, in our lab, eggs are about a 92% thaw rate, embryos more in the 98 to 99%. So still a small increase, but the egg, the ability, that's where we've put a lot of our efforts, is to catch up with oocytes. Oocytes allow individuals to still female patients to have reproductive autonomy over those eggs. Once you make an embryo with a partner, that becomes community property, essentially. You have to have both parties agree to utilize that embryo. Eggs, you're the boss. So glad we've been able to catch up with oocytes. So both require ovarian stimulation, and we'll go through that in just a second. Specialized center with expertise. So we do an ovarian stimulation cycle. So remember, that conductor is going to go in, regardless of where we are in the menstrual cycle. That conductor brought eggs out to the ramp. We're going to use 10 to 12 days worth of injectable meds. We're watching on with ultrasound and blood work over that process, on average 4 to 5 times during that 2-week period. We then undergo an oocyte retrieval to retrieve the eggs under anesthesia. It takes about 15 or 20 minutes. We then preserve the oocytes, or we fertilize with sperm. And really, the downside to this approach is that it's only an option for either peripubertal or postpubertal patients. So specifically talking about breast cancer, refer all premenopausal patients to reproductive medicine for if desiring future pregnancy. We can utilize a medication called letrozole. It's an aromatase inhibitor, especially in these estrogen receptor positive breast cancers. In a standard oocyte cryopreservation cycle, we can see estrogen levels up into the 2,000, 3,000, 5,000 picograms per ml. So our role and our goal utilizing letrozole, which again is an aromatase inhibitor, 5 milligrams per day, is that the aromatase inhibitor is incredibly effective at keeping estrogen levels even lower than we would see in a natural menstrual cycle. So the oocytes continue to develop under the control of that injectable gonadotropin, but in addition, we can use letrozole to make sure that risk is mitigated in estrogen receptor positive cancers. So pregnancy after treatment, especially in breast cancer, generally considered safe. No increased risk in short-term data. Traditionally, we recommend at least 2 years disease-free before attempting conception. And as it seems in the literature, present day, temporary interruption of endocrine therapy for pregnancy has no bearing and is definitely an option. So when do we start this? Well, in a perfect world, or what we thought was a perfect world, dogma in the world of in vitro fertilization and controlled ovarian stimulation with injectable medications, was we like to start that cycle in what we call the follicular phase. Cycle day 2 to 3, with cycle day 1 being first day of full flow. Cycle day 2 to 3, we start our injectable meds when all those eggs have just gotten out to the ramp. We want to make sure that we can rig the competition and get as many eggs as we can. Well, when we see a patient in the office that is looking to start chemo in 1 week, 2 weeks, 3 weeks, we don't have that luxury. So we do what's called a random start. So the random start is, what day are you today? Terrific, we'll start tomorrow, right? So we go after, because remember in that analogy, even if that winner has already ovulated, there are still several eggs out on the ramp that we can go and rescue prior to their atresia and that conductor going in and getting another cohort of eggs. So what we have found, random versus follicular starts, is that there's no significant difference in any of the important measurable entities. Total oocytes retrieved, fairly equal. Mature oocytes, right? So in the process of controlled ovarian stimulation, we want follicular development for a number of days because we need those eggs to become mature haploid cells. They kick out a polar body and they become haploid where they can be fertilized. So mature oocytes retrieved are equal. Fertilization rates are also equal. The benefit of a random start is time. I see a patient on a Thursday, I start them on a Friday or Saturday. 2 weeks later, we're wrapping them up in a pretty little bow and handing them right back to you guys. So with the eggs in liquid nitrogen. So we can complete things, and I give patients about a 2 to 3 week max just to get everything lined up. So ovarian tissue cryopreservation, newest player on the block. It's now established, but very new. No ovarian stimulation required. Can be done immediately if emergent therapy is required. It's the only option for prepubertal patients. certainly we've found some pretty interesting evidence that it can restore both fertility and ovarian hormone function when reimplanted. Some of the success rates, live birth rates after transplantation, pregnancy rates are quite good. Ovarian function. So remember, the ovary is not there just for reproduction. It's there for important hormones, estrogen, testosterone, etc. So resumption of menses is very protective for heart, bones, mind, those types of things. So the function of the transplanted tissue can seem to stay steady for 4 to 7 years after transplant. So some of the considerations, it does require laparoscopy or surgical procedure prior to the start of chemo. Later transplant is needed for the tissue to become effective. And there is a risk of reintroduction of malignant cells, especially higher risk in bloodborne cancers such as leukemia. How do we do it? Well, there's 2 different ways to do it. There's the ovarian cortical tissue cryo, where you can cryopreserve 1 to 2 millimeter slivers of the ovarian cortex. And then when you go to reimplant, 2 different types of implantation. There's orthotopic, where you can put the ovarian tissue back into the pelvic site or in the ovary or the ovarian fossa, the ovarian bed. Or heterotopic, where the tissue is placed in a site other than the pelvis, such as the forearm or the abdomen. Whole ovary cryopreservation, not necessarily effective. This is an area of focus where the issue with whole ovary is that the cryoprotectants can't get to the tissue. That's where the slivers become very important, where the cryoprotectants can get to the tissue so that when they are exposed to very cold conditions, such as liquid nitrogen for storage, the ability to be functional when thawed still remains. This is a picture of an ovarian segment, a piece of ovarian tissue that is grafted onto alloderm. This is, so Kokturk Oktay, a doc up at Columbia, is a colleague of mine. He has been at the forefront of ovarian tissue cryopreservation. And he's published a nice series of articles about the utilization of tissue. The picture here is one where he's prepared a segment of ovarian tissue for reimplantation. It's embedded on a graft of alloderm and then can be placed right back into the ovarian bed with robotic surgery or laparoscopic surgery. So other things in addition to oocyte, embryo, and then ovarian tissue cryopreservation, sometimes ovarian transposition or oophoropexy, that's a mouthful, for patients requiring pelvic radiation and the success is not guaranteed due to the radiation spread, should be performed closer to the time of radiation. We spoke a little bit about GnRH agonists or leuprolide acetate in the world of gynecology is one that we use a lot. I know that in pediatrics and in oncology, there are several other analogs of GRH that are available. The whole goal with this is just to shut down the HPO axis. What we're looking to do is put the eggs in the dome to sleep until we're done with chemo. So that can be a monthly injection while chemotherapy is happening. It's not to replace established methods, but certainly to be utilized as an adjuvant. May be offered for breast cancer patients, my opinion, all cancer patients, may benefit biologically female patients, may benefit those who need to undergo urgent chemo and we don't have time to get eggs, and there is a known protective effect on ovarian function post-chemo. One of the more investigational methods of cryopreservation is in vitro maturation. It is emerging. This is where we go in without any ovarian stimulation, go get immature eggs, and then in the lab we would need to figure out how to make them mature so that they can fertilize. Very limited data. So what's the impact of age on outcomes? So oocyte quality declines with age, we know that. For oocyte cryopreservations in less than 35-year-old individuals, we've got 15.4% live birth. As the number of eggs go up, we increase the number of the live birth percentage. Ovarian tissue cryopreservation, while it is a new established technique, it has been shown to be effective. The message here is earlier the better. This is a summary table that you can read at your leisure. It just kind of goes through the methods of embryo, oocyte, ovarian tissue cryopreservation, the live birth rates, and then some of the key considerations. How many people come back and use this tissue? Not many, but still it's available. Most recent published data that we have was a large trial or a large study that looked at a 5 to 7 year follow-up. Only about 5%, 5 to 8% of patients came to and used those oocytes. 78.5% were able to get a usable embryo. Cumulative live birth rates close to 30%. And then not surprisingly, the older patients were more apt to come back sooner to utilize those eggs. As far as ovarian tissue cryopreservation, again, this is mainly done in the pediatric population, so not surprising that the number of the recipients is still fairly low. Other special populations, the prepubertal, we mentioned that ovarian tissue cryopreservation is really the only option. There's no live births yet reported from prepubertal tissue, but I think as the years go by, we will start to see it. Males, we talked about testicular tissue cryopreservation. So not just pretreatment. Can we offer this to patients who have undergone treatment already? While the outcomes may be lower, they're certainly not zero. Patients who did not preserve gametes initially are welcome to have conversations about what a cycle would look like. Those needing additional preservation techniques for family building. Survivors at risk for age-related fertility decline. Anyone that has had gonadotoxic therapy have a risk of having premature ovarian insufficiency. For biologically female, embryo oocytes may still be offered, as well as males, limited post-treatment options because the sperm may be compromised, but we're always willing to give it a shot, certainly after that 1 year. Some of the barriers, system level, patient level, right? Reproductive medicine is not immune to these, like you guys see in several of your patients. Lack of insurance coverage, financial constraints, and certainly disparities exist between age, race, cancer types, and socioeconomic status. Now, what is the solution, or one of the solutions? 21 U.S. states plus D.C. now require insurance coverage, private insurance coverage for fertility preservation. And I am proud to announce that Louisiana did follow suit in 2023. I think some people in this room had a large part to do with that as well. Myself, one of my partners, Nicole Ulrich, at Pheno, have to give credit to the docs at Fertility Answers in Lafayette and Baton Rouge, Neil Chappell, John Storment, Representative Paula Davis, and then Katie Bliss, one of our reproductive attorneys here, patient of fertility medicine as well as patient advocate. Tremendous effort put towards this. And yes, it's incomplete, but it's something. It's a start. It started the conversation. It started the ability of us to get in and to move legislation in the right way. Without insurance, out-of-pocket costs can range $6,000 to $10,000. Medications, $2,000 to $6,000. Sperm cryo, cheaper. I want to say some patients may be able to afford the consult alone. I can only speak for the Fertility Institute. Private insurance, no insurance, state-based insurance, we will never decline a fertility preservation consult based on inability to pay. Patients they deserve at least a conversation. So if there is no coverage and inability to pay, we will gladly do those conversations pro bono. A phone call for me, for them, it's priceless, right? So we welcome the opportunity for any conversations about fertility preservation. Matter of fact, my 15-year-old, my very apt 15-year-old was a state Medicaid patient. Mom was concerned about cost, and if I would not have done that phone call, I don't think I would have had one of the most impactful phone calls I've had in the realm of fertility preservation. We do have some great partnerships. Some of our pharmaceutical companies, Ferring is one of them. EMD Serono is another. There are various programs that we can get very low cost, if not free meds. Screen, clinical flow. Definitely need to screen patients who assess gonadotoxicity. Step 2 is refer. Step 3 is coordinate. And then step 4 is to follow up. And the big thing about follow-up is we need to reassess on an annual basis during survivorship. The essential team, it's definitely a round table, right? I mentioned that round table earlier. Multidisciplinary, oncology, REI, mental health, financial, nursing staff, patient advocates, former patients who have gone through this, huge patient advocates. Coordination's needed, timely fertility consults, assess fertility preservation treatments, financial navigation, psychosocial support, future directions. We mentioned IVM, in vitro follicle maturation. We need to improve protocols. I'd love to do this quicker, but with better results. Online risk assessments, research needs. We need long-term follow-ups, cost-effectiveness trials, better patient satisfaction and morbidity rate, better coverage, better payment plans. So take-home messages, would love to reiterate: diagnose early, discuss early, refer liberally. Multiple options exist. Welcome patients to have those conversations. We'll talk about established methods, whether it's embryo, oocyte, sperm cryo, ovarian tissue cryo. Some of the successes, they range 25 to 40%. Time matters, but options exist, pre and post. Post-treatment preservation, worth a conversation. Document everything: discussions, referrals, decisions in the medical record. The bottom line is fertility preservation is an essential component, and we welcome the opportunity to play a role in it. So I appreciate your time. Thank you for everything that you do. Thank you for the opportunity to be here.